So shortly after that, 15th of May, out comes Mark's book. And Mark's going to pick up the story from here. But I just want to say what an extraordinary achievement Mark has made here. It can't really be overstated what he's done single-handedly, starting from nothing, often groping for threads in the dark. He's actually found something new in the field of cancer. And we know how many people would like to be doing that, and they haven't done it. But Mark has found something new. So, Mark he's part of a rising movement of what you call citizen scientists. I've shown you a few others who are on our panels there. And this is an extraordinary new force in cancer, and is going to bring some great things to the arena. Those other citizen scientists are also doing extraordinary work. Anyway, from my point of view, absolute privilege to have had that letter from Mark and to be asked to help him to launch his theory on the world. And I'm delighted to be here as the warm-up act for him today. Okay. Yes.
While they're getting ready, Dr. Milton White was one of the first scientists to make the connection between fungal infections and cancer, and he visited the Riordan Clinic during the RECNAC days. And ironically, I did a podcast on the fungal link to cancer in 2002, and it's a bit embarrassing to think that it just didn't go anywhere. But I'm thrilled that Mark has been able to not only to take up the cause, but to so thoroughly and scientifically articulate what this really is. And so, are you ready to go, Mark? So please welcome Mark Lintern.
Thank you very much. Well, it's an absolute pleasure to be here and be sharing this platform with so many brilliant minds today. So thank you, Dr. Ron and the Riordan Clinic for inviting me here today. And thank you, Robin, for that fantastic introduction. Wow, how do I follow that? And if I'd known you were going to blow my face up as big as that on screen, I would never have given you that image. Or at least I would have photoshopped it first. But thank you for that. So, yeah, absolutely fantastic. So, hi, I'm Mark Lintern, and today I'll be taking you through an unconventional journey that challenges conventional thinking to present a new interpretation of cancer. Now, whether you agree with me or not, I hope to give you a different lens through which to view the data. I don't expect to convince you today. That would be very unrealistic in a single presentation. But what I hope to do is plant a seed of curiosity that perhaps in time that idea can grow. Okay, I'd like to draw your attention to this quote from Alan Turing. Sometimes it is the people no one imagines anything of who do the things that no one can imagine. I love the humble undertone of this quote. It reminds us to remain open-minded in our discourse because sometimes answers can be found in the places we least expect them. A sentiment that will be echoed throughout my talk. Okay, that's not working. Bear with me just a second. Right. Unfortunately, cancer affects us all in some form or another. It has a way of breaking lives apart, leaving unanswered questions, and an aching sense of powerlessness. While many want nothing more to do with cancer after they've lost someone close to them, some take that devastation and use it to create something really extraordinary. A determination to fight back and transform that pain into hope for others is one thing that a number of people have done and do. Under these circumstances, impactful change can arise from the place we least expect it. So I'd like to share 2 examples of such a response today, and how those 2 forces came together to develop what we've currently developed at the moment. And Robin really covered those very well, so I'll skip over them quite quickly. So for Robin, his moment of defiance against cancer came from the heartbreaking loss of his daughter Bryony. So what happens when cancer crosses the path of someone like Robin? Out of the rubble of such heartache, Robin created the cancer charity Yes to Life, a UK charity that has advocated for an integrative approach to cancer since its inception 20 years ago, long before integrative medicine became popular. It also is one of those rare charities that supports innovative ideas. As a result of his exceptional work, King Charles awarded Robin an MBE, making him a member of the Order of the British Empire. Here he is accepting his award from Princess Anne. Congratulations, Robin, for such a prestigious accolade. Very well deserved. All I ask is that you stop winning so many awards so the rest of us can actually enjoy some ourselves. Okay, for me, my moment of defiance was triggered by my own diagnosis and the heartache of losing a dear friend to the disease, Sam. So what happened when cancer crossed my path? Some would say I went a little crazy and started scribbling incoherent scripture on all over the walls. While that would make for a very entertaining story, the reality is a little bit more bland. I used a whiteboard. What began as a desire to make sense of Sam's loss led to years of research trying to determine which DNA mutations were responsible. Sorry, let me go back 1 second. The more I studied the genetics of cancer, the less likely DNA mutations seemed to be driving the disease. There was no clear pattern to explain cancer's consistency. As I came to understand the cancer landscape better, patterns and consistencies started to emerge. Pieces of the cancer puzzle started to fall into place, and one thing led to another. And before I knew it, after 8 years, I'd written a new theory of cancer, which I call the Cell Suppression Theory. More on this in a moment. Okay, so what would happen if these 2 forces come together? Robin's very eloquently explained this. Robin would probably propose a ludicrously ambitious challenge, which I would probably blithely accept without too much thought for the magnitude of the proposition. And Robin's perfectly explained that. That's exactly what happened in 2023. We orchestrated a landmark event. Landmark event called Cancer Through the Lens, where I presented my research to a panel of 10 experts and debated them in front of an audience of 200 medical professionals. Here's the panel, as we've already discussed. I won't go through them again because Robin did a fantastic job. And it was gratefully received by everyone, and I was very humbled to have that final vote, which gave us the signal really to carry on with my research and push this forward. And here's Professor Michael Lasanti making that statement. Mark has presented a coherent model of carcinogenesis and the mechanism of cancer, which is very, very nice to hear and very humbling too. So shortly after that, as Robin presented, I published my theory in the book, The Cancer Resolution, which has won 2 literary awards so far. It's written for the layperson to understand. It's also been translated and published in French. At present, I'm a finalist in the UK Life Sciences Innovator of the Year Award, beating around 100 participants to be one of 5 remaining finalists. The winner of the award will be announced on the 21st of November in 2 weeks. My work is making ripples in the medical field. I've spoken at a number of conferences, while others are discussing my work and how it may help inform clinical practice. My research also features as part of a master's degree course at Exeter University. Here's Professor Neil Gow taking me through his lecture with my book featuring as part of the module within the course. Neil Gow is Professor of Mycology at Exeter University. My work has sparked the creation of a research group of which Robin Daly is the chair. We meet every month with the aim of testing the theory. This is just a snapshot of one of the earlier group discussions. I'm hugely grateful to everyone involved and humbled by their generosity as all these scientists and clinicians are all offering their expertise and time for free, which speaks volumes about their integrity and the sincere dedication to advancing human health. Here we are seeking a collaboration with Molsheim, a German company that produces the sepsis test, capable of identifying a broad range of pathogens. In this call, we're connecting with Professor Ravid Straussman from the Weizmann Institute of Science in Israel. And here we're meeting with Dr. Robert Nagorny from the Nagorny Cancer Institute in America to establish a collaboration. So there's a lot of interest in my work, and awareness is growing steadily as it makes its way into the world. Now, there are many cancer theories proposing a different origin of the disease, none of which have been proven. So what elevates the cell suppression theory above others to justify my presence here today? Well, it's the first theory to comprehensively explain all 10 hallmarks of cancer, rendering it one of the most accurate cancer theories currently available, or at least on paper. This indicates I have possibly identified a key mechanism driving cancer that, if targeted, has the potential to improve survival outcomes for all cancer patients. There is even the possibility that I may have uncovered the origin of cancer, if there is such a thing as a singular cause, that is. To quickly explain, these hallmarks represent the consistent features of cancer. All theories are attempting to explain them. The more hallmarks explained, the more accurate the theory is deemed to be. This is important because treatments are developed from cancer theory. The greater the accuracy, the more effective the theory's associated treatments are likely to be. Now, this is where cancer theory can be very useful because it can be used as a practical tool to help us determine the most effective treatment options. At a time when all theories remain unproven, but vary in their ability to explain the disease, these hallmarks can provide a measurable framework that can guide our treatment choices. So for argument's sake, let's say only 2 cancer theories exist. In a situation where theory A explains all 10 hallmarks and theory B only explains 2, you'd obviously want to choose the therapeutic approach associated with theory A because it has more likely identified a key driving mechanism, rendering the treatment associated with that theory potentially more effective. As a patient, I found the cancer landscape confusing and very overwhelming. It's extremely difficult to work out which treatments and interventions you should choose because there are so many and there's a lot of contradictory information. But through understanding the accuracy of cancer theory, we are provided with a roadmap of what to target and why. Now, there are 10 accepted hallmarks of cancer, although 4 have recently been added. For the purpose of this presentation, I'll focus only on the 10 that are well established. Okay, so what is the mechanism I propose and how does it differ? At present, malfunction is the guiding concept that underpins nearly all established theories. Okay, so that is, cancer is currently thought to arise from damage to the cell or cell malfunction. Different aspects of the cell are damaged: DNA, mitochondria, the tissue surrounding the neoplasm. But no person, to my knowledge, has questioned this cell malfunction premise. It's treated as an unspoken truth and silently guides the direction of research and all interpretations of what cancer is thought to be. But what if cancer isn't driven by malfunction? Could this one assumption explain why we've struggled to understand and treat the disease effectively? Challenging established thinking and offering a completely new paradigm, the cell suppression theory proposes that cells are operating under duress from a position of suppression, not malfunction, which speaks to what Robin was saying earlier about our body always working for the benefit of us. This is a paradigm shift in thinking. It sets the cell suppression theory apart from all others. Significantly, this new insight has enabled the explanation of many missing pieces of the cancer puzzle and offers the potential to increase the efficacy of current therapies. Now, before we dive into the detail, I should tell you a little bit about my background. You may have already gathered that I'm not a medical doctor or a geneticist. In fact, my degree is actually in graphic design, which is a fancy term for colouring in for a living. Now, I realise that may sound unusual in this setting. What could a graphic designer offer the medical community? Let me explain why my unconventional background may be of benefit. At our core, graphic designers are creative problem solvers. We are original thinkers who are hardwired to challenge consensus thinking. It's how we produce original designs day in, day out. Moreover, graphic designers are required to balance creativity with logic to facilitate good functional design. Now, chaos is the result of creativity without logic. Here are two examples of a lack of logic leading to chaos. Have you ever tried assembling an IKEA flat pack using the instructions? And have you ever tried to make sense of politics? A fool's errand, if ever there was one. Okay, the ability of graphic designers to think both creatively and logically are rare traits that can sometimes benefit other disciplines when applied effectively. As Albert Einstein once said, logic will get you from A to B, but creativity will get you everywhere. Of course, I don't pretend to match your expertise in clinical oncology. I've stood on the shoulders of giants to get here. I have enormous respect for the depth of knowledge and rigour that comes from a formal medical and scientific training. My contribution comes from a different angle. First principles thinking, systems thinking, pattern recognition, curious self-directed study, and a willingness to ask naive questions. And sometimes naive questions can be useful, especially if progress stalls. There are advantages that arise from self-education, notably the freedom to follow curiosity where it leads, without being confined by a syllabus or pressured to defend existing ideas. The self-taught mind can roam, and sometimes that freedom to question and connect things differently is exactly what opens the door to new discoveries. Here's a short list of notable autodidacts who have made major contributions to science. Okay, in medical training, it's necessary to simplify complex systems. For example, cancer is often taught primarily through the genetic lens. But if we treat genetics as the whole story rather than just one chapter, we risk missing other important dynamics. In this respect, while a formal education shapes our understanding of the world, it can limit the questions that we ask. And sometimes discovery comes from the creative mindset that questions that framework itself. For instance, despite there being a number of different cancer theories, the majority of resources are disproportionately committed to the genetic theory. Vital research required to investigate cancer's origin and different treatment possibilities suffer as a result. The caveat of such a narrow approach to problem solving is evident in the following question. What if cancer is not a genetic disease? From an outsider's perspective, looking at the problem objectively, it makes little sense to focus all our resources in one area when so much remains unknown and when progress appears to have stagnated. Again, I'm not saying I have all the answers, but under the circumstances, the view of an outsider with a fresh take on the disease could make all the difference. So why do we need to rethink cancer? Excuse me. While progress has been made, for instance, the 10-year survival rate has doubled in the last 50 years to 50%. That's fantastic. We are all gathered here today because we acknowledge more needs to be done, and that instinctively the sense is that we are missing something. In fact, it's only when we start to look a little deeper do we see the cracks. For instance, relying on the survival rate as a measure of success can be misleading. For example, between 1976 and 1995, prostate cancer survival increased by 16%, which is great. but mortality in the same time increased by 45%. This is a reflection of improved diagnostics and surgery, not necessarily an improvement in our understanding of the disease and how to treat it. It is therefore misleading to only focus on the survival statistics. While scientists have created some fantastic drugs that greatly extend life for some, the average increase in life extension for all chemotherapy drugs analysed between 2003 and 2014 was only 2.2 months. While 2.2 months can feel like a lifetime for a cancer patient, it's a far cry from the cure we're all hoping for. When we look at the survival outcomes of late-stage cancers, it becomes evident we have a lot more to do. And there's also the issue of the reproducibility crisis, where around 75 to 90% of landmark papers that inform our current understanding of the disease appear to be incorrect because they can't be replicated. So what's gone wrong? Why are we struggling to make significant headway despite the immense effort and investment already made by so many? There are two possible explanations. I think there's two possible explanations, possibly three, but I'm going to stick with these two at the moment. Cancer is a genetic disease, but it's just too complex for us to fathom at the moment. Or B, the established theory that guides most of our decision-making is incorrect. For me, the danger is clear. We appear to be pursuing option A while ignoring the very real possibility of option B. So, how should we proceed? We shouldn't give up on option A, but we should share our resources more equally. Incidentally, option B is the approach I've followed and I followed over the last 8 years of my research, the outcome of which has been to identify a new potential mechanism behind cancer and that is capable of explaining all 10 hallmarks. This is a significant breakthrough that stands to redefine our understanding of cancer and how we treat it. Okay, to even consider other perspectives, though, we must first assess the validity of the established theory, as this will justify the need to investigate other interpretations. So, are there sufficient contentions with the somatic mutation theory? Yes, is the simple answer to that. The first contention being that some cancers develop without driver mutations at all. So, at the very least, we should be investigating why that's the case and what's driving those particular cancers or those examples. The second is that oncogenic mutations that are said to drive the disease have been found in healthy tissue without cancer developing. The mutation rate of around 7,042 tumour samples recently analysed showed only 1.7 mutations on average, too few to account for cancer's 10 hallmarks, now 14. DNA transfer experiments, which were discussed a little bit earlier regarding Thomas Seyfried and metabolic theory. Those transfer experiments resulted in normal growth as opposed to the abnormal growth we would expect if DNA mutations were driving the disease. This is where DNA was taken from cancerous tumours and transferred into healthy cells. We expected to see abnormal growth, but we didn't see that occurring, which strongly suggests that DNA is not driving abnormal growth. Mutations appear to be random from one cell to the next, and even within the same tumour. So it's not clear how such utter randomness could cause the consistent hallmark features of cancer in different tissue, let alone the same tissue. There's a big question mark there. Number 6, cancer cells revert to normal when placed within healthy tissue of the same type, despite mutated DNA remaining present. So this was proponents of the tissue organisation field theory undertaking this experiment. This speaks to a terrain-based signalling issue rather than a genetic issue. These are only some of the serious contentions that challenge the genetic basis of cancer and strongly indicate some other mechanism is at play. When analysed, we find that the somatic mutation theory struggles to explain more than 2 of the 10 hallmarks of cancer for these reasons. Until these and more contentions are addressed, we cannot say with any confidence that DNA mutations are responsible. The lack of significant progress in treating the disease also justifies investigating other perspectives. So what do other experts think of the shortcomings of the established theory? Well, proponents of the tissue organisation field theory state, We argue that it is necessary to abandon the somatic mutation theory. Significantly, Professor Weinberg, who is co-author of The Hallmarks of Cancer, admitted in 2011 that up until the last 5 years, we haven't understood the problem. Professor Thomas Seyfried highlights that the debate around the origin of the disease is far from settled, and he's quite scathing in his condemnation of the support for the somatic mutation theory. Okay, looking elsewhere, there are several other theories worth considering. Of the 6 listed here, 3 stand out: the metabolic theory, the cancer stem cell theory, and the tissue organisation field theory. All describe features that are present in all cancers. Of those 3, the metabolic theory appears to be the most accurate. This is significant because it addresses a core consistent feature of the disease. And when it comes to solving complex problems, consistency is king. The metabolic theory describes the Warburg effect, so I'll just go very briefly through it. I'm sure you already know about this already, but just for anyone that doesn't. It describes a metabolic shift that occurs in nearly all solid cancers, suggesting it is a pivotal feature of the disease. To keep things simple, let's say there are 2 energy pathways that operate within a cell. They are called OXPHOS and glycolysis. OXPHOS occurs within organelles called mitochondria and combines glucose with oxygen. Glycolysis ferments glucose without the need for oxygen. It is a less efficient and is often used as a backup energy pathway to support OXPHOS. Obviously, metabolism is a lot more nuanced than I'm describing here, so please forgive me for this simplification. Healthy cells generally use OXPHOS, especially when oxygen is available. But cancer cells operate differently. They choose to use glycolysis even when oxygen is available for mitochondria to use. Proponents of the metabolic theory suggest that this is because mitochondria become defective and are incapable of generating energy via OXPHOS. This naturally forces the cell to rely on the backup energy pathway of glycolysis to survive. This abnormal reliance on glycolysis, even in the presence of oxygen, is known as the Warburg effect, named after Otto Warburg, who discovered it in 1924. This reliance on glycolysis is said to drive cancer. The origin of cancer, according to the metabolic theory, therefore, is that mitochondria are defective, specifically a defective OXPHOS energy pathway. This leads to an abnormal reliance on glycolysis, which goes on to drive the disease. Now, this is significant because the Warburg effect is a consistent feature of nearly all cancers, which is why abnormal metabolism features as one of the 10 hallmarks. This is where things start to get interesting from a problem-solving perspective, because understanding and explaining the consistency of cancer is the path to identifying the origin of the disease, in my opinion. The relevance of the metabolic theory is shown in its ability to explain at least 7 hallmarks, which elevates it above the somatic mutation theory. Metabolic cancer therapy should arguably dominate standard of care treatments for this reason alone. Now, Professor Seyfried, who is a main proponent of the metabolic theory, claims that all 10 hallmarks can be explained. And for a while, I was in agreement with him until I discovered a few significant contentions. While I am in agreement with Professor Seyfried that the Warburg effect is a pivotal feature of cancer involved in driving the disease, these contentions led to me to question the narrative that defective mitochondria were responsible for the Warburg effect. The hallmark contentions are avoiding immune destruction, resisting cell death, deregulating cellular metabolism, also known as the Warburg effect. Whoops, sorry. Okay, so starting with immune evasion, Professor Seyfried provides a really good example, actually, of this. Chronic inflammation, he describes excess lactic acid, scarcity of glucose and other nutrients, as well as macrophage fusion, helps to explain suppression of the immune system at later stage disease. However, no direct mechanism is presented to explain why the immune response fails during the initial stages of tumor formation. So there's a question mark there. Regarding apoptosis, the cell death mechanism, it is claimed that cancer arises because mitochondria become irreversibly damaged, which inhibits cell death because mitochondria control the cell death mechanism. In the words of Professor Seyfried, as mitochondria control apoptosis. Defective mitochondria means that the kill switch no longer works. Yet studies into plant compounds, including bromelain, honey, and even silver, show that apoptosis can be reactivated in cancer cells through the mitochondrial-dependent cell death pathway. This suggested to me that there was a suppressive mechanism at play rather than one that is defective, because the mechanism is clearly working. These two contentions aside, this leads me on to the primary contention. The entire premise of the metabolic theory rests on the notion that defective mitochondria result in defective OXPHOS, suppressing mitochondria's ability to create energy. This causes a switch to the Warburg effect, where cells rely on glycolysis to create energy. However, OXPHOS appears to be operational in many cancers and can be upregulated under nutrient deprivation or restricted to inhibit cancer cells. Professor Seyfried argues that all studies claiming this have misinterpreted the oxygen consumption rate, and on this point I do agree with him. However, there is sufficient additional evidence to show that OXPHOS is still operational. Again, this suggests to me that there's a suppressive mechanism at play rather than one that is based on malfunction. Now, Professor Seyfried even admits that pathogenic mitochondrial DNA mutations that would be required to explain the loss of OXPHOS are not present in cancerous mitochondria, and that this is controversial. Furthermore, children with Barth syndrome who share the same Warburg metabolism and cardiolipin abnormalities found in cancer, yet those children with Barth syndrome, despite showing these abnormalities, cancer is extremely rare in that disease. And when we do see the required mechanistic damage, cancer does not arise. So oncocytomas are characterized by defective mitochondria and defective OXPHOS. The exact conditions required for cancer to form under the metabolic model. However, oncocytomas form a very slow-growing benign tumor. The conclusion from this study is that OXPHOS is required for malignancy, challenging the metabolic theory narrative. Now, probably the biggest one is prostate cancer. It's the most prevalent cancer in men by a huge margin, and yet it is not actually initiated by the Warburg effect, which is obviously claimed to be the driving mechanism behind the disease. This is why early prostate cancer is not detectable using a PET scan. Prostate cancer is effectively the elephant in the room that no one has yet been able to explain. While the Warburg effect does occur in late-stage disease, prostate cancer is initially driven by fully functioning mitochondria and OXPHOS. So I just want to be clear, I'm not discounting the metabolic theory. On the contrary, the Warburg effect or abnormal metabolism is a pivotal mechanism behind cancer in my view. From a problem-solving perspective, identifying the cause of the Warburg effect is the key to solving cancer, in my opinion. Whatever is driving this abnormal metabolism, common to nearly all cancers, is likely to be the origin of the disease. I'm simply proposing a different interpretation of Warburg metabolism in cancer and what's driving it. Now let me pause just there for a moment. The consensus is that cancer is a multifactorial disease, and in part I agree. But there's a difference between a cause of cancer and its origin. While I agree that the cause of cancer and the treatment required to combat it are both multifactorial, I hope to show you that the origin is not. Opening ourselves to the possibility of a singular cause allows us to catch a glimpse of what cancer might be, and through this lens, cancer starts to make sense. Identifying consistency is the key to establishing root cause. Consistency can be found in all aspects of cancer, despite the apparent chaos and randomness that we see. It is this consistency that sheds light on a common origin regardless of tissue type. This is the beauty of the Warburg effect. By identifying the root cause of this consistent metabolic shift, we should be able to identify cancer's origin. I think I went a bit too quick there, sorry. So could the Warburg effect be driven by something else? yes is the simple answer. So now I will redefine the Warburg effect through a suppression-based model. To understand this, we can turn to the work of Dr. Robert Naviaux and his cell danger response model. Naviaux proposes that upon exposure to danger, such as injury, stress, toxins, and infection, all cells run through a well-orchestrated and predictable programmed response that consists of 3 phases. CDR1, the defense and isolation phase, triggering inflammation and immune stimulation. This is where toxins and pathogens are targeted and removed. Once dealt with, the cell moves on to the next phase, CDR2, the repair and rebuild phase, which is highly glycolytic and proliferative. When complete, the cell moves to CDR3, the resolution and normalization phase, where inflammation subsides and normality resumes. What's interesting is that this model presents an alternative explanation for the Warburg effect in cancer. So for context, the Warburg effect, according to the metabolic theory, is characterized by the following features. Defective mitochondria inhibit OXPHOS. This generates reactive oxygen species, and glycolysis is upregulated despite oxygen availability. Now here's the critical insight that changes everything. The cell danger response describes what happens when an infection occurs. During infection, we see that glycolysis is also upregulated despite oxygen availability. Reactive oxygen species is also increased, but something slightly different. Mitochondria intentionally inhibit OXPHOS. They do this to use the oxygen to combat the pathogen. What Dr. Naviaux is describing here is the Warburg effect as an intentional response by mitochondria to infection. This is the subtle difference that sets my theory apart from the metabolic theory. In essence, this intentional suppression of OXPHOS may have led to the wrong conclusion that mitochondria are defective. Now, mitochondria are the cell's primary sentinels that detect infection by sensing disruptions in electron flow. In response, they suppress OXPHOS to repurpose oxygen to combat the invading pathogen by regulating reactive oxygen species. ROS is also used for inflammatory signaling and immune regulation. Glycolysis is upregulated to provide the ATP energy required to support mitochondria during this cell defense response. This can explain why cancer cells paradoxically continue to absorb high rates of oxygen despite the OXPHOS pathway allegedly being defective. Glycolysis, with its increased need for glucose, depletes glucose in the surrounding tissue. This is another anti-infection strategy that aims to starve pathogens of their primary fuel. Now, to confirm this is the case, abundant evidence shows that intracellular pathogens have evolved to hijack Warburg metabolism and push host cells into a state of increased glycolysis when the host would otherwise use OXPHOS for energy production. Infection triggers the Warburg effect. This was my light bulb moment. I was reading a paper on infection, nothing to do with cancer at the time, and it mentioned that Warburg-like metabolism was induced by epithelial cells as an infection response. But no one, when I looked in the literature, had seemed to have made or pursued this any further to make the correlation with cancer. We also see that once established, Warburg-inducing pathogens persist with the host, inducing Warburg metabolism, offers benefits such as access to key nutrients and protection from the immune cells. Long-term intracellular survival is the goal of these pathogens. Now, this is all good and well, but aren't tumours sterile? For such a theory to hold any validity, these pathogens would need to be present in all cancers. And this is exactly what we find. By 2017, Ravid Straussman discovered that all 35 cancers he tested contained intracellular bacterial and fungal pathogens. This has become known as the tumour-associated microbiome. His findings have since been replicated. Now, pancreatic cancer offers some interesting insight. Aykut et al. Discovered that Malassezia fungi proliferated 3,000-fold in pancreatic tissue. Antifungal therapy reduced the tumours by up to 40% and prevented them from growing. Reintroduction of Malassezia fungi triggered tumour growth once again, confirming that fungi could drive pancreatic cancer. In an intriguing case study, a pancreatic patient survived a terminal diagnosis when he was provided with a 9-month course of the antifungal drug itraconazole to eliminate a fungal infection. His inoperable tumour became operable, it was resected, and over the following years, no relapse occurred. Additional work on the microbiome in cancer highlights that fungi were found to promote tumorigenesis in different body sites, such as lung, breast, skin, brain, bone, ovary, colon, head and neck, and stomach cancer. In fact, the fungal microbiome is now being touted as a new hallmark of cancer, such is the strength of the correlation. This next point is extremely important, as it provides insight into how and why a tumour develops. Infection not only triggers the Warburg effect in the infected cell, but it also triggers the Warburg effect in surrounding non-infected cells. So hundreds of cells work together collectively to eliminate the infection by intentionally triggering the Warburg effect. This occurs via a communication pathway between cells known as purinergic signaling. Significantly, and only a low biomass infection is required to elicit a feed-forward cascade of Warburg-like metabolism in neighbouring non-infected cells. In other words, a small infection can trigger the mass adoption of the Warburg metabolism and proliferative growth in healthy cells surrounding the infection. What does this mean for a tumour? It means that the majority of the tumour is potentially made up of non-infected cells intentionally switching to the Warburg metabolism for the purpose of pathogen elimination. This graphic helps illustrate the composition of the tumour and how it all fits together. So the red dots here represent pathogens and infected cells. The cream or yellow cells are healthy, non-infected cells that have adopted Warburg metabolism. What we see is that most of the tumour comprises of cells that are not infected. This explains why biopsies may come back negative for the presence of pathogens and why they have not been considered as causal. This can also explain why immune cells fail to recognize the tumour, because by and large, most of the cells that comprise the tumour are not seen as foreign. They are regular cells, responding as they should to a small but potent infection. The Warburg effect is a normal response. A failure to eliminate the initial infection results in a corrosive and inflamed environment that suppresses immune access and creates a protective niche that enables the pathogen to thrive. The infection expands as the tumour slowly expands. So referring back to Dr. Navio's model, I propose that the failure to eliminate the pathogen, coupled with the ongoing chronic inflammation and excess cell damage that occurs, leads to a conflict in the cell danger response, where the cell repair cycle becomes stuck between the inflammatory state of CDR1, the ongoing attempt to eliminate the pathogen, and the proliferative repair state of CDR2, required to repair the damage that's now occurring. This helps to explain the persistent and unrelenting growth of a tumour. Not only do these intracellular pathogens trigger and sustain the Warburg effect, but they also suppress apoptosis, preventing the cell death mechanism from firing. Put together, the ability of these pathogens to hijack these mechanisms perfectly explains the generation of a tumour. Of course, my research didn't stop at explaining the Warburg effect and apoptosis. Not only am I able to provide a detailed explanation for all 10 of the hallmarks of cancer, but through the lens of fungal infection in particular, I've been able to explain at least 20 additional features associated with the disease that largely remain unexplained by established theories. This strongly indicates that fungal pathogens are serious contenders for the origin of the disease. Okay, so I will now walk you through a comprehensive explanation of carcinogenesis through a cell suppression lens. Under healthy conditions, inflammation is resolved and healthy tissue function returns once the cell danger response is completed. Problems occur when inflammation becomes chronic, Under these conditions, immune suppression can occur. Prolonged inflammation and Warburg metabolism results in excess lactic acid, iron overload, and glucose scarcity. This combination over a long period of time suppresses immune function at the site of inflammation. This opens the door to opportunistic pathogens, providing they are present in sufficient number within the affected tissue. Fed by a poor diet, high in sugar, and overexposure to antibiotics, a dysbiotic microbiome becomes dominant in fungi and takes hold. While lactic acid and iron overload suppresses the immune function at the site of damage, both fuel fungal virulence, providing the perfect conditions for cell invasion and supporting the pathogen. Inflammation and immune weakness further facilitates this process. Okay, so cell invasion occurs through several avenues. There's more than the ones that are mentioned and shown here, but manipulation of EGFR and HER2, E-cadherin loss and via endocytosis, to name a few. Stimulation of these growth receptors encourages tumour growth signals. Fungi actively modulate the immune response to evade detection. This can occur via upregulation of PD-L1, nagalase, avoidance of the dectin-1 pathway, and modulation of the Th1, Th2, M1, M2 axis, to name a few, all being mentioned as key features of cancer. These can all be driven by infection and fungal pathogens. So these are all features present in cancer as well. So let me just move on from there. Okay, so the Warburg effect is then sustained as we go through the process because the intracellular pathogen is not eliminated. And as previously mentioned, cells surrounded infected cells are also switching to suppressing the OXPHOS and triggering the Warburg effect in a collective effort to combat the infection. This locks hundreds, if not thousands, of cells into a proliferative metabolic state. These same metabolic pathways we see upregulated in cancer are also the same pathways upregulated during infection. These are the ancient evolutionary survival pathways in early development that protect cells from pathogens. This upregulation of old survival pathways explains the atavistic theory of cancer proposed by Professor Paul Davies and Charlie Lineweaver in 2014. To ensure their intracellular survival, fungi upregulate BCL2 to suppress apoptosis, preventing the cell death mechanism and preventing the cell from essentially hitting the kill switch. This leads to the formation of a tumour, aided primarily by the surrounding non-infected cells that also adopt proliferative Warburg metabolism. The infected cell essentially influences surrounding cells like a queen bee would influence the bees in a hive. Excess lactic acid and upregulation of MMP9 caused by the fungal pathogen itself triggers angiogenesis, generating blood vessel growth. Ongoing damage caused by pathogen toxins, methyl deficiency, loss of E-cadherin and reactive oxygen species generates random DNA damage, lipid droplet formation, and retrograde signaling. This random DNA damage is thought to be the origin of cancer and forms the basis of the somatic mutation theory. Incidentally, many of the common DNA mutations found to increase cancer risk and are said to drive cancer do so because they facilitate infection. They do this by either a loss of immune function, as is the case with the loss of P53, suppression of mitochondrial function, as is the case with the BRCA1 and 2 mutations, or downregulation of E-cadherin, as is the case with CDH1 in stomach cancer, APC, and HER2. And there are many other mutations that I've not got down here. Fungal pathogens also downregulate E-cadherin to aid with the infection process. The metabolic theory proposes that lipid droplet accumulation in cancer cells confirms that OXPHOS is defective, because this suggests that fatty acid oxidation cannot occur. But lipid droplet accumulation can equally be the result of infection. It is a mechanism deployed to protect oxidation of unstable fats reacting with reactive oxygen species during infection. Fungal pathogens can also modulate lipid droplet formation for their own benefit. Preventing the cell from initiating the cell death mechanism leads to the excess damage to mitochondrial DNA, which results in retrograde signaling, where mitochondria communicate with the nucleus to trigger a survival mechanism. This survival mechanism instigates a transition to a stem cell-like phenotype via an epithelial to mesenchymal transition, generating cancer stem cells. This is a well-known response to excess stress and cell damage. During the metastatic stage of disease, we see that many circulating cancer cells are covered in a sticky protein called galectin-3. This appears to aid migrating cancer cells adhere to distant tissue and is often blamed for this. But what we find is that galectin-3 is actually an antifungal protein, suggesting that there is a presence of fungal pathogens. Galectin-3 is deployed to inhibit fungal pathogens by sticking to their cell wall, but its sticky nature appears to inadvertently aid metastasis. The combination of excess lactic acid, MMP9 upregulation, and E-cadherin loss directly caused by the fungal pathogen enables cancer cells to break away into the bloodstream, while cancer stem cells, macrophage fusion, and galectin-3 aid distant seeding and metastatic growth in a new location. Not shown in this graphic, exosomes from the primary tumour communicate with the distant tumour to sustain Warburg metabolism. This may explain the abscopal effect, where treating the primary tumour results in the reduction of distant metastatic tumours as well. This can be explained through the elimination of the fungal pathogen in the primary tumour and the subsequent reduction in exosome signalling to the distant tumour. Effectively, as the fungal threat is eliminated, so too is the requirement to sustain Warburg metabolism, resulting in distant tumour resolution. This may only occur in distant tumours that don't contain a fungal pathogen, which may also explain why it's a rare phenomenon. Okay, here I have redefined cancer's hallmarks through the lens of fungal infection. This novel infection may explain why cancer fails to develop even when the required DNA mutations or oncoviruses are present, and when cancer develops despite DNA mutations and oncoviruses being present. When oncoviruses are not present. So I propose that cancer requires the presence and influence of fungal pathogens. Without sufficient fungal load and sufficient damage to the cellular terrain, cancer will not form. I also argue that it's no coincidence that we are now seeing a renewed interest in repurposing antifungal drugs for cancer therapy. In particular, itraconazole shows efficacy against many cancers, as do many other antifungals. So is the drug effective because it's targeting metabolic pathways, or the fungal pathogen, or both, is the question I'm asking. What I also find particularly interesting is that most of the repurposed drugs that appear anti-cancerous also possess strong antifungal properties. Is the success of these drugs a result of them inadvertently targeting the fungal pathogens that I propose are driving the disease? In terms of research and development, this opens the door to the development of new antifungal drugs that better target these pathogens and cancer as well. Okay, in terms of treatment for cancer, I'm not a clinician, so I can't advise on this, but my research suggests we should target some extra things that we may not be targeting at the moment. So that would be fungal infection within the body and the tumour, if we can identify the fungal load, mycotoxin exposure, microbiome health, and heavy metal exposure too. It also suggests that we should be factoring in the presence of fungi when making all treatment and lifestyle decisions as standard. In particular, we should place greater emphasis on modulating the immune response, addressing microbiome imbalance, and consider using antifungal drugs and natural means to eliminate fungal infection and their biofilms. As bacteria are also present within tumours and can work synergistically with fungi, it would be wise to consider how these bacteria may influence drug efficacy by either improving or inhibiting it as well, and considering the relationship with other microorganisms such as parasites. So, in conclusion, does the cell suppression theory better explain the hallmarks of cancer and offer additional treatment options that may help improve survival outcomes? I believe it does. If my theory resonates with you, you'll find it in the Cancer Resolution, which can be purchased from Amazon using the code above. And I'd just like to thank you all for your attention and being such a wonderful audience.
Any questions?
I was wondering if you could expand a little bit or reiterate. I missed a little bit when you were talking about the abscopal effect.
Yep.
And how you thought that worked.
In the sense that if you treat the primary tumour, the distant tumours will also be treated without any sort of treatment. The explanation being for that the primary tumour and the other tumours that have metastasised act because they communicate with each other almost like a hive mind, in the sense that you have the fungal pathogen is present, say, within one particular cell or a small area of the tumour. The rest of the tumour is adopting the Warburg effect to try and eliminate the pathogen. The primary tumour is sending signals to the distant tumour exosomes to say, look, we still have this issue with this infection. So the cells that are distant still believe they're part of the original tissue. So they're receiving this information to say, sustain that Warburg proliferative metabolism, because we need to still eliminate this pathogen that isn't eliminated. So you treat the initial infection, you eliminate the pathogen, you eliminate the signaling to the distant tumour, and they resolve themselves without being treated. Okay.
Go ahead. Yeah, go ahead and speak.
I'm really impressed with this. And this is very similar to what Dr. Semencini of Italy had done about 20 years back. I think he was jailed for calling cancer a fungus. So,
Yes.
So he was actually using sodium bicarbonate for treatment of cancer. What do you feel about that?
Again, I'm not a clinician, so I can't advise on that. I'm not entirely sure exactly how he's using it. I know it's antifungal, but I know there's issues with you want to be careful with reducing the acid in your stomach. I'm not sure if he was injecting it or having people ingest it, but I think there are a number of studies out there that show that it can be beneficial. But I would need to study that more.
Have you sat with any integrative oncologists and tried to take this this whole theory and put it into a therapeutic protocol? Even here, though I don't like protocols, have you tried to do that?
Well, at the back of the book, I've got 2 chapters on potential solutions that advise patients of what to look for, and I'm in the process of doing that. Because every person is individual.
Yeah.
Their treatment history, their microbiome, their current health status, how they react to drugs. So there'll always be that individual aspect, but there is a fundamental foundational core treatment approach that we can have, looking after the terrain, getting the body back to full health as much as we can. And then from that, we can look at potentially helping with antifungal drugs or interventions, natural interventions that are anti-cancerous, and then looking at the off-label drugs as well, but look at it from a perspective of, let's use this particular off-label drug that can target the metabolism, but use the off-label drug that's most effective at targeting the particular pathogens that might be driving the disease. But also key would be to test for mycotoxins and test for the fungal load in the body, so we know, at least have an idea of which fungal pathogens we might need to target.
Yeah, it seems to me that just a lot of what we normally do anyway is antifungal. You know, in integrative therapies in general, whether it's reducing sugar, increasing immune function, changing the all of the terrains, you're basically setting up the terrains to, if you can set them up to be antifungal or to allow the fungi to be quiescent. I think fungi are there But if you can keep them quiescent, you'll be fine. You know, if you can change all these things. But it's in the American and the Western world diet and stress and all the other factors, it's really setting people up to be fungal infected and then setting them up for the cancer. That's my opinion. So I think, is it time to move on to the next phase? Thank you, Mark. Let's one more hand for Mark. Thank you.